So I'm sure everybody has rushed from operation theaters. As anesthetists, no, we have been usually busy in theater since morning, and we always some of them are in middle of their journey to reach home. So we have started these webinars to have a discussion about important topics which affect everybody, whether it be a senior anesthesiologist, junior anesthesiologist, or depending on the place they are working, whether we are working in a corporate setup or a government setup. So we'll be starting with a pre-anesthesia assessment topic today, which is the essence of first step in anesthesia whenever patient comes in. So first I will invite Dr. Lokesh sir for a welcome address for the webinar. Lokesh sir, please.
Hello, good evening, welcome friends. I think we have almost about 50 people who have joined us on this webinar. It is the effort of young people like Amit Kohli, Nishkarsh Gupta, and others who have been able to start this webinar series. Mainly it is for the benefit of the residents so that they could understand more. Pre-anesthesia checkup is a very important thing before anesthesia. I still remember when I had done my diploma from Maulana Azad Medical College in, say, about 84, patients would be referred to a PSC clinic, and none of the patients who was not made fit from the PSC clinic, he cannot be taken up or he cannot enter the OT at all. Which was quite strange because a lot of patients who were diabetic, hypertensive, or some other problems, and Maulana Azad not having a super speciality, it was very difficult to, they would never get fit. And then they would look for friends, the surgeon would look for friends to get their cases done either in emergency or in a semi-elective way. Later on, at times we saw that all patients, of course there is a PSC clinic, but most patients are seen one day before, and any investigation or any consultancy can be done a day before, which helps, especially in complicated cases. So it is very important to know before we start anesthesia that the patient is well controlled, and so that we don't land up in a problem during the intraoperative period. So thank you very much for attending the webinar. Dr. Nishkarsh, please.
Thank you, sir. Thank you for the kind words. Sir is the president ISA Delhi, and this is the first time we have started under his leadership the webinars of ISA Delhi. Now I invite, since Vice President is not there, Honorable Secretary Amit Kohli to say a few words before we can proceed.
Thank you, Dr. Nishkarsh. Actually, as Dr. Lokesh has already mentioned, that under his leadership and vision, we'll be starting our webinar series for mostly all trainees and postgraduates under anesthesiology. Right. As you all know, that national bodies are also holding these webinars. Right. So rather than keeping a day fixed, what we have done is we are keeping the date fixed for all our postgraduates who have joined us today. So it will be most likely the fortnightly webinars. 13th is the day for every month, which is fixed. And at the end of the month, we'll be announcing soon what is the date at the end of the month, where we'll be holding another webinar series. This is for the teaching and training purpose of all the students who are getting a training in anesthesiology. Right. I'm very pleased to see our senior faculties who have agreed on a very short notice to be part of this webinar. Right. That is there across corporate sector as well as teaching institutions. Right. Who has graced this particular webinar for the benefit of our students, and it will continue in the coming days as well. I request that in the chat box, the students should put down queries, right? If they have from any of our speakers or the panelists, that will be taken at the end of the panel discussion, right? And I take this opportunity to invite all of you to ISA Delhi YuvaCon, which will be on 6th and 7th April 2024 at Maulana Azad Medical College, New Delhi, which caters a lot of activities in addition to those deliberations and panel discussions. And paper and poster presentations. We'll be having a lot of art competitions, literary competitions, and a very good cultural evening, followed by a gala dinner. So I invite you all for that. Over to Dr. Nishkarsh for the conduct.
Thank you, Amit. now I invite Abhijit, our treasurer, for a few words before we can go to the actual webinar. Abhijit, please.
Thank you, Nishkar sir. It's been a long-awaited project of ours to start off with this academic series from Delhi ISA. I am very thankful to Dr. Lokesh sir for his visionary ideas and Dr. Amit Kohli sir for executing them. And most importantly, all our esteemed faculties who are there with such a short notice, and they have agreed for this. And to add to Dr. Amit sir's word, I would request all the members and the faculties present here to come up with ideas which will help all spectrum of anesthesiologists, maybe a resident, maybe a trainee, maybe a consultant, all kind of practical aspects and topics, so that we can take this ahead fortnightly. And just last but not the least, please come forward and join YuvaCon. I think you have all seen the brochures, and please make sure the reach increases. And that's it. Enjoy the session. Thank you so much. Over to you, Nishkar sir. I think Dr. Arvind Arya sir has joined, sir.
I think I can see Arvind. Dr. Arvind, good evening. Okay, so we can maybe have him later. So now we'll start with the first topic for the today without wasting much more time. So now we have Dr. Michelle Gulabni, and she is Associate Professor in UCMS. She will be speaking on an important topic, risk assessment in anesthesia. And there is a reason that we have chosen her, because she is a co-author of one of the chapters in risk assessment in upcoming South Asian edition of Stolting. So she'll be taking us through this in about next 15 minutes. Over to you, Michelle.
Thank you, sir. Good evening, respected seniors, teachers, faculty members. It's my privilege to take this session today. I'll just start sharing my screen to start. Good evening, everyone. The goal of preoperative evaluation is to ascertain the patient's medical status and ability to withstand anesthesia for the planned procedure. Well-informed and prepared patients are more satisfied. Hence, there is a reduction in anxiety, improved acceptance of regional anesthesia, less delays, cancellations, and lower operative costs. There are various components of pre-anesthesia evaluation which range from clinical and airway assessment, risk stratification to patient education and informed consent. Let's look at some of the epidemiological highlights. Now, perioperative complications are a huge public health burden and one of the preventable causes of morbidity and mortality. The statistics state that 1 out of 4 patients who undergo major surgery will develop complications amongst an estimated 300 million procedures performed worldwide. The various risk assessment predictors are, is there something coming, sorry, on the screen, sir? Is my screen visible, sir?
Screen is visible, but there is some mark. I'm not sure from where it has come.
Yeah, I don't know how it has come, sir.
But I think we should proceed because there's something coming, but must be at your end, because since you are sharing, so it is unlikely somebody else.
I'll stop sharing and start again, sir. Just a second. IPS. I don't know why this is coming. Just a second, sir. Is it still coming, sir?
Now it's okay.
Thank you, sir. Sorry for the delay. The assessment of the various risk factors can be classified into patient factors, surgical factors, and biomarkers. We'll discuss about each one of them in detail. Now, the most common used patient factors is the American Society of Anesthesiologists Physical Status Classification, which status. So the updated classification helps to include special groups of patients, pregnant ones, those being prepared for. So this is a normal pregnant patient and a well-controlled gestational hypertension, as well as a diet-controlled GDM, all come as ASA2. And as we increase in the ASA classification, preeclampsia with severe features becomes 3, HELP becomes 4, and that's how it proceeds in the other examples of adult and pediatric too. Then the limitation of this classification is that it is basically a subjective classification and varies widely among clinicians, especially non-anesthesiologists. Also, it does not consider the risk for the inherent planned procedure. So functional capacity assessment. Now, cardiorespiratory reserve is a good predictor of perioperative risk, and it is assessed by the level of activity. The common subjective assessment tools are the inability to climb 2 flights of stairs or walk 4 blocks, and this significantly increases the risk of postoperative cardiopulmonary complications. A commonly used method to assess this is the 6-minute walk test, in which the patient is asked to walk on a selected corridor for 6 minutes. Heart rate and SpO2 are monitored throughout the procedure. A healthy subject can walk 400 to 700 meters, and the total distance walked is calculated. Besides this, the magnitude of desaturation, timing of heart rate recovery is actually very significantly associated with the clinical outcomes. A commonly used measure is the METS or metabolic equivalence, and for METS activity without symptoms is considered to be a good prognostic indicator. However, the objective tests have more clinical implications, like the Duke Activity Status Index, which is a simple test of 12 standardized questions that relate from routine activities to heavy jobs done. And this is calculated to the metabolic equivalence. Another test is the cardiopulmonary exercise testing or CPET, which is done as the patient bicycles on a treadmill for 8 to 12 minutes, and it simulates real world scenarios in a controlled and regulated manner. It is a vital tool for preoperative assessment for lung dissection and monitoring exercise capacity in heart failure. It also helps to differentiate the various causes of dyspnea. An important interpretation of this is the maximum oxygen uptake, or the VO2 max. Its normal value is more than 85% of predicted. So each pathology, whether it's the cardiovascular, ventilatory, or pulmonary vascular, have significant characteristics on CPET, and that is how we can differentiate the various etiological factors. The RCRI, or Revised Cardiac Risk Index, is another commonly used measure in which 6 parameters are included as risk predictors, and each of them is given a score. The risk varies from 0.4% in the absence of any risk factors to 5.4% when 3 or more risk factors are present. Then biomarkers have emerged as a recent good tool for clinical assessment. Albumin of less than 30 grams per liter increases significantly the risk of perioperative morbidity and mortality. And anemia is another strong predictor for adverse postoperative outcome. BNP and pro-BNP are also coming in a large way and are considered to be useful in patients above 65 years or those between 45 to 64 years with significant cardiovascular abnormalities, and there should be assessed elevated preoperatively. Perioperative AKI markers include preoperative creatinine, NGAL, cystatin C, and liver fatty acid binding protein. Now, there are also certain surgical risk factors, like the American College of Surgeons National Surgical Quality Improvement Program, or ACS NSQIP Surgical Risk Calculator, which calculates the chance of an unfavorable outcome after surgery. And the various post-operative outcomes are sudden cardiac arrest, renal failure, thrombosis, wound infection. Each outcome is ranked from 0 to 100% at intervals of 10, and the risk of this patient in particular is calculated as compared with the average patient risk. It helps to determine the risk of perioperative adverse cardiac event, or PACE. So the PACE ranges from more than 5% for a high-risk surgery to less than 1% for low-risk procedures. Another commonly used score is the ARISCAT, or Assess Respiratory Risk in Surgical Patients in Catalonia. It helps in predicting the post-operative pulmonary complications and includes various parameters. And similarly, scores are given and the percentage varies from 1.6% to 42% according to the scores given. Another commonly used method is the POSUM or the POSUM score, which includes 12 physiological indicators and 6 operative indicators. Each of them is given a score, and for these, the samples are collected 24 hours before an elective surgery and 6 hours before an emergency surgery. It is a simple, easy, and effective way to calculate the incidence of complications, keeping into account both morbidity and mortality. It is also a useful tool for research and audit. However, it has certain limitations, like it does not take into account the factors which lead to differences between the surgeon's anesthetists and operating times. Also, diagnosis is not included in POSUM, and it often tends to overestimate the mortality rate. Keeping an account of this, the Portsmouth POSUM or the Peace POSUM was developed, and this retains the same variables but uses a different mortality prediction calculator. The utility for this is mortality data estimation. However, it is not used for trauma patients or for evaluating mortalities after trauma surgeries. Now, operative risks. There are certain classifications like the Johns Hopkins risk classification, which is purely based on the operative risk, independent of the anesthetic procedure at all. So for a minimally invasive procedure with no or little blood loss, we classify it as category 1. A surgical procedure in which you expect a blood loss of not more than 500 ml, you classify it as 2. Similarly, you go to 3, 4, and 5 as the surgical risk increases. So these risk classification is totally based on the operative procedure, not on the anesthesia risk. Another surgical prediction calculator is the surgical mortality probability score, and it is used for non-cardiac surgeries, and it is a 9-point scoring system which helps to predict the 30-day mortality risk index. It uses the ASPS, emergency nature of the surgery, and the surgical risk. Again, scoring is given and the mortality is predicted according to the level of score. So in a nutshell, we can classify these scores on whether the operative intervention is involved, whether it is not involved. So the scores like POSUM, P-POSUM, Johns Hopkins, surgical risk scale, these involve the operative intervention. However, ASA, Apache, Goldman cardiac risk index do not involve the operative procedure at all. Now for emergency laparotomies, the NELA or the National Emergency Risk Calculator has also been used, which estimates the risk of death occurring within 30 days of an EL. Includes various parameters. Each predictor is coded and a color specific for each, and it has a specific percentage to calculate the overall risk. For post-operative care is the surgical APGAR score, which is calculated on the basis of anesthesia records during the surgery, estimated blood loss, lowest MAP, and lowest heart rate. However, it cannot predict the morbidity and mortality before the surgical procedure. Various other emergency scores are like the emergency surgery acuity score, the physiological emergency surgery acuity score. In special populations, these perioperative risk stratification varies slightly because in these patients, the physiology of the patient is altered. Therefore, we need separate classifications to include them. For obstetric patients, emergency surgery should be performed regardless of any trimester. However, non-urgent surgeries that cannot wait until delivery, the second trimester is preferred. Now, completely elective surgery is best delayed until delivery. For pregnant patients with a history of heart disease, the CARPEG score is useful for perioperative evaluation. It includes various risk factors like dyspnea grade, history of cardiac events, mechanical valves, or ongoing cardiac ailments like CAD and pulmonary hypertension. Each predictor is scored and the percentage is from 5 to 40%. For PPH, you have 3 other scores which classify the patients into high, medium, or low risk, taking into account the past, present obstetric history, BMI, and thrombocytopenia. Now, pediatric patients. A child with URTI operated under GA is always a matter of concern for the anesthesiologist, as it increases the risk of perioperative respiratory adverse events, which include laryngospasm, bronchospasm, and so on. And the Pediatric Perioperative Cardiac Arrest Registry states that after cardiovascular causes, respiratory are the most common for perioperative cardiac arrest, with laryngospasm being the most common. The appropriate timing is always a concern to the anesthesiologist. So 2 to 4 weeks is good for an elective surgery. For an urgent or semi-urgent procedures, the risk and benefits should be weighed after discussion between the surgeon, anesthesiologist, and caregivers. And the patient should be medically optimized as time permits if the decision to proceed with surgery is made. This is the cold score for a child with URTI whom GA has to be given, which includes the current signs and symptoms or for onset of symptoms. L for the presence of injury. Scores are given accordingly, and this helps to ascertain all the risk factors, though it does not actually give a cutoff by which we can ascertain whether anesthesia should be given or no, but includes all the important risk predictors. Now, elderly patients often present to us these days, and they should be assessed for their cognitive ability and limitations to understand the nature of surgery. They need to be screened for depression and other factors of post-operative delirium. Also, they should be evaluated for substance abuse and history of falls. Now, frailty is a very strong predictor for adverse outcomes rather than age alone. So patients more than 65 years undergoing a major operative procedure should be screened for frailty. They are predisposed for neurocognitive disorders post-surgery. And patients who have fallen for 3 or 4 times in the past 6 months acquire 100% risk of perioperative complications. Also, those dependent for daily activities have a higher incidence of adverse effects. Now, there are various systemic diseases like diabetes, hypertension, and whether it's your murmurs or CAD, which are beyond the purview of this, and it might be dealt in the panel discussion. Let's go now to an important but last section of informed consent and making a decision. Risk assessment parameters are used as a part of shared decision making and informed consent. And informed consent not only protects the patient's right, but also enables them to take care of their own health, improving physician-patient relationship, and also reduces the medico-legal litigations in case of any complications encountered. Informed decision-making and patient consent should be both voluntary and knowing. Also, the patient must be competent to give a valid consent. Competency or capacity means that the patient must have the ability to understand how he is going to make the decisions and about accepting or refuting the options being offered. Also, the physician must disclose the material facts and other appropriate disclosures before the patient makes an informed consent. Material facts are those which are relevant, whether they are invasive diagnostic techniques are being utilized, and also includes the proposed treatment, alternative options, risk and benefits for the ongoing procedures, and even if he chooses not to go ahead with the surgery. So the patient should be informed about all additional procedures also that might be necessary. Communication between the physician and the patient should always be done in a common language. And lastly, documentation of the informed consent decision by the surgeon who will be performing the surgery is of paramount importance. So risk assessment is basically an interplay of multiple factors between the surgeon and the anesthetist, where shared decision-making and informed consent are very important locking tools, taking into account the various parameters, and there is no single risk assessment tool which encompasses everything. So it's actually a mix of all these factors and which help in making the informed consent and decision-making easier for the patient and giving clarity and helping the surgeon also. Thank you for your kind attention.
Thank you, Michelle, for this lucid talk. This is a difficult topic to handle, and in a short time, you have broadly covered the important risk tools for preoperative risk assessment. So we'll have the questions in the end. We'll go to the next panel discussion. We have Dr. Akhilesh with us. Michelle, you can stop sharing the screen now.
Yes, sir.
So it is good to see we touched 90 some time back. So good participation considering we have a first webinar today. So Dr. Akhilesh, all of us know, is professor at RML Hospital. He's a very jolly person and well published and loved by residents at RML Hospital. So we can see some of the residents are sleeping still attending. So it shows the popularity of our webinar. So Akhilesh, over to you. You can please introduce the topic and your panelist.
Yeah, thank you, Nishkarsh sir, and thank you, sir, for making me a part of it, and I'm obliged. We are having a panel discussion on preoperative assessment. So I like to invite Dr. Jayashree Sood ma'am. She doesn't need any introduction. She is senior consultant and chairman of Department of Anesthesia, Sir Gangaram Hospital. I like to invite Dr. Anju Balhotra ma'am. She is director professor at Maulana Azad Medical College. Welcome, ma'am. I'd like to invite Dr. Deep Arora, sir. He is a senior consultant in Max Group of Hospitals. And Dr. Ankit, he is additional professor at AIIMS in Delhi.
Akhil.
Akhil.
Yeah.
I think Dr. Rajiv is not there. So I was saying that he had some issues, so he wouldn't be there. So
Akhilesh, one small correction. मेरे उसमें ना आप लोग advisor लिख दो. Advisor Institute. Okay.
ठीक है मैम.
Thank you.
Okay. So we'll starting with the preoperative assessment, and as Dr. Michelle had rightly pointed out, and did the risk stratification of a patient, and that's mainly the reason why a patient comes for PAC checkup. Patient comes for PAC checkup primarily for two things. One is risk stratification, and another is to optimize what all patient can be optimized. Dr. Jayashree Sood ma'am, when is PAC done for a first time in a patient? Suppose a patient comes for TKR with no comorbidities. So when is the first time PAC done, and who sees the PAC just one day before?
Our usual rule is, of course, it's not that it is a rule that has to be completely 100% followed. We're not very rigid on it, but usually we say that whenever the patient comes to the OPD of the surgeon, that is the time that a PAC should be asked for. And most of the time they do it, but sometimes for any reason that they can't, then once the patient gets admitted, we do it the night before. But it is always recommended to have it done before, which is followed 75% of the times. And the advanced PAC, of course, a consultant has to do. Now, supposing it is a TKR and a consultant is doing it, but he or she will always consult the anesthesiologist who is supposed to be conducting that case. And how do we come to know who's the anesthesiologist? Because for our need TKRs, we have 2 senior consultants who are dedicated. So anything can be discussed with them. So the seniors or the specialists of that branch are always consulted before for any decision or for any remarks that may be added. So that's it. Except for the daycare patients who are ASA1, they come on the day of surgery.
Okay, ma'am. I'd like to take an opinion from Anju ma'am, because she being in a government setup, things might not be same as in the private setup. So ma'am, what is your opinion on it?
Our setup, normally the surgeons will, again, when the patients come to the OPD, if they're planning to do the surgery in the near future, they will send the patient to the PAC clinic. We have a PAC clinic daily, and the team sitting there will assess the patient. And once the patient anything has been asked for, or the patient needs to be optimized, all that is done at the level of the PAC clinic. The patient may need to make a couple of visits more to the PAC clinic until he is completely optimized. And then they will admit the patient. And after that, the patient will be seen a day before by a member of the team who's going to conduct the case the following day. That is our protocol usually. If there's some very high-risk patient, then the sensible surgeons will refer them to the consultants perhaps a couple of weeks in advance so that we can optimize a patient in a better manner. But normally we get a 2-3 days period to prepare our patients in our setup.
So we can take from here that anyways the patient is seen by the team who will be anesthetizing the patient one day prior.
Yes, that is always done. Yes.
That is always done. Okay,
yes.
Ma'am. Dr. Akhil, normally what questions do you ask in a routine PAC? Suppose we say there's a patient of gallstone disease coming for lap cholecystectomy, 30 years old, no other comorbidities. So what all you ask in a PAC history?
Yeah, so I mean, like you said, this is probably an ASA1 or an ASA2 patient. They are generally fit otherwise besides their gallbladder disease. So a brief history of any previous illnesses they might have, specifically diabetes, hypertension, any history of tuberculosis or bronchial asthma. If they've had any, if they've undergone any procedures previously under anesthesia. If yes, then what kind of procedure, what anesthetic, if they know, and if there were any adverse outcomes during that procedure. And lastly, before the examination, obviously, any history of any known drug allergies. We are more and more frequently we are seeing patients who come up who are probably because of the more awareness about this particular issue, but people come up with stating that they have a penicillin allergy or a sulfur drug allergy, something like that. So these are the few questions we ask in generally ASA 1 or 2 class patient.
Yeah, that's a very valid point, because sometimes drug allergy importance is not given. Yesterday only we are calculating around 10 PGs out of 90 PGs have a latex allergy. So drug allergy is becoming very common these days. Coming on to Deep sir, what is the routine preoperative evaluation is done in a ASA 1 patient?
In our center, ASA 1 patient, we just do a CBC, viral markers, because that is mandatory for any patient going into the operation theatre complex, and that is it. We don't subject them to LFT, KFT, and anything else, unless the age of the patient is more than 60 years. Then we do, for more than 40, we do an ECG as well, and more than 60, we may do other tests. But otherwise, we do not.
So we can take that in a patient less than 40, you are getting CBC and viral markers, nothing else, sir?
Nothing else.
Jayashree Sood ma'am, is it the same at your institute also?
Yes, absolutely. Young age with a simple surgery, and naturally not an elaborate one, which I'm sure that's what Deep also meant. We just do the CBC, that's it. And the markers are in any case ordered by the surgeons.
Okay, ma'am. Coming on to airway examination, Deep sir, do we always do a complete airway examination, or we just look at 2 or 3 specific markers in an airway examination?
We do, see, unless there is some obvious abnormality or obesity or heavy jaw, we just do a normal Malampati, mouth opening, the extent to which it opens, prognostication, and that is it. Nothing more elaborate than that. But we do it in every case, but in spite of the fact that 99% of our surgeries are under regional blocks, but still, because of, like you rightly mentioned, drug allergies are more common, and we've had a couple of anaphylaxis in the last 6 months, 2 of them. And in both instances, we were glad that we had done the airway examination, and we were prepared for the, to take care of the airway.
Thank you, sir. Yesterday, when I was talking to Anju ma'am, we discussed about that there is a difference between a pre-anesthetic evaluation and a pre-operative assessment. When we talk about pre-operative assessment, it is first done when a patient comes to the surgeon. And when we talk about pre-anesthesia evaluation, it comes when the patient is coming for the anesthesia. So there is a good time lap between the pre-operative assessment and a pre-anesthetic workup. And during that time, there's something called prehabilitation, which started. And the patient is optimized and patient is prepared during that point. Anju ma'am, anything you'd like to add on that?
If I may say, acute examination, actually, I think in today's date, when we have such good predictors of airway and we have such good equipments like video laryngoscopes and fiber optic bronchoscope and supraglottic devices, it is more important, I think, to rule out a difficult bag mask ventilation rather than a difficult intubation. Because now it has been found that there are no actual predictors that are available for use with video laryngoscopy. Like Dr. Deep said, yes, definitely mouth opening or inter-incisor gap, a minimum. Another one is the ability to pronact the jaw. Number 2, that is a minimum. And the third minimum probably is the thyromental distance. These must be done just to rule out. This is the minimum screening for a difficult intubation. But difficult intubation is not the problem. The problem is going to always be difficult bag mask ventilation. So we must be very careful of those predictors which are for difficult bag mask ventilation, like the presence of beard and obesity, radiation to the neck. And even actually Mallampatti 3 and 4 are also associated with difficult bag mask ventilation. So when you're coming to that, I just wanted to add, these are minimum 3 for intubation, and more stringent, again, I'm repeating, we need to look at bag mask ventilation. That is going to save our patient, not the intubation. We should be able to ventilate our patient. Then what was your question? Sorry to me.
Ma'am, I was asking about prehabilitation.
Yeah, now, like we were talking, see, pre-anesthesia evaluation, some of the editorials are now saying that is a term that is given that you are the anesthetist and the patient has come to you and you have to give anesthesia in the next couple of days. So that is so you will prepare the patient for surgery, say tomorrow or day after tomorrow, where you do not have time for prehabilitation. But now with the patient's expectations have gone up and the outcomes of anesthesia, at one time it was just patient go to sleep, patient should wake up. That was anesthesia. But now there are very long-term markers of the quality of anesthesia that we give. You want them to be rapidly discharged from the hospital. You want there not to be any residue of your anesthesia. There are so many markers and risk stratification, like Michelle has told us. So prehabilitation should ideally start as soon as a surgeon sees a patient, and then the surgeon has to initiate this whole process of pre-anesthesia evaluation, which is going to, it's a multidisciplinary approach in which we have to involve the anesthesiologist, the respiratory physicians, the surgeon, the dietitian, and then we have to get the patient optimized as much as possible, autologous diet, the blood donation, all these things. So this should take a period of 3 to 6 weeks if we have the time. And now is the time that we should be insisting in all of our hospitals for prehabilitation as part of the pre-anesthetic evaluation. So rehabilitation is after it's happened and after the surgery is over. Prehabilitation is when you want the outcomes to be good. So you want to do all these things, like I said, whether it is exercising, it is breathing exercises, it is muscle training, it is nutrition, blood sugar control, blood pressure control, it all has to be done for a period of 3 to 6 weeks where we have the best possible outcome for the patient.
Yeah, just to summarize, there are 4 components of prehabilitation. One is a medical optimization, as ma'am had said, that blood sugar control and physical exercise. It again becomes very important when patients come for a bariatric surgery. So they get a physical exercise, they get a nutritional counseling, and a psychological counseling again becomes a very important part of a prehabilitation. More so in a patient who is coming for some onco surgery, because when they go to a surgeon, that's the first time they come to know that, yes, I have a tumor. And till the time the patient comes for a surgery, that's a significant time. So it's important that patient gets psychological counseling also.
Sir, if I may add, just for the residents on our webinar, there's a prehabilitation, like ma'am already said, important part of IRAS protocol as well. IRAS is the relatively new thing going on, and the easy way to remember prehabilitation is basically nutrition, exercise, and worry. Counseling helps to alleviate the worry of the patient, and these 3 prongs form the basis of the prehabilitation program.
Another important aspect would be to stop smoking.
Yes, yes, sir.
Yeah, to reduce alcohol if possible. Yeah, all these things.
And can I just add, Akhilesh, that
Yes,
the point was, of course, very valid about 4 to 6 weeks. But sometimes, as Deep will agree with me, prehabilitation for so many weeks may not be possible in the private sector. Because as soon as a CA is diagnosed, naturally the surgeon also wants to, although the surgeon understands. So the major things, of course, he might wait for a few days, but not weeks. That's our practical problem, but definitely we do optimize them.
Yes, ma'am, that is a practical problem. Even for the poor patient, ma'am, they will not be able to have nutrition. They don't know how to exercise. So these are a little theoretical as of now, but they are the future.
They're very important. Absolutely, yes, very important.
So in our place, the patients will run away. If you leave them for 6 weeks, they will probably not come back, or they will probably die in the meantime if they don't do any of these measures, So it is a concept that it will take time to get into place.
Akhilesh, just want a small thing. So, ma'am, absolutely. The only thing is that in these patients, whatever little time we have, that should be utilized. That should be the aim.
Very true. Very
We
true.
will not be waiting for 2 weeks, 4 weeks. Mostly, we don't have it even in our setup for various reasons. And secondly, Deep sir said about alcoholism and smoking is a very valid point, because in that period they are receptive to suggestions. So they might actually listen to you, and eventually they get reformed to not having to that extent. So that opportunity should be utilized as far as possible to do that.
So coming on to preoperative assessment, we'll start with system-wise. Coming on to Anju ma'am, suppose there is a 40-year-old patient, a known smoker for 20 years, and the patient comes for lap cholecystectomy. So what all preoperative assessment you will do, and what will be the preoperative considerations in such case? Ma'am, you are not audible, please.
When a patient with the known patient of a smoker, so if he's a smoker for how many years, we have to first see the duration of smoking. More than 20 pack years of smoking is when, after which the small airways start getting affected. So we need to know the amount of smoking, the duration of smoking, and that can be computed by the pack years. Then we need to know about his symptomatology. We need to know whether he's got any cough, what is the amount, what is the color, what is the frequency of that. Is he in a good phase? Is he in a bad phase? Is he having an acute exacerbation, or is he in the stable phase? Because they will always have some degree of cough. Then we have to find out whether they're taking any drug therapy, whether they're compliant for the drug therapy. Have they been hospitalized in the past for any of these, for any respiratory complaint? Then, of course, we have to examine him. So we have to know about his exercise tolerance, whether he has already developed impaired, damage to the lungs and impaired exercise capacity. So we have to know about his functional capacity. And that can be done by all those tests that Michelle was talking about. The 6-minute walk test can be done. The shuttle test can be done. Or better than all these tests is actually just taking a very, very good history. If a patient can walk 2 blocks or can climb 2 flights of stairs, that meets our requirement of 4 METs. So if the patient can climb 2 flights of stairs at a reasonable pace, not after stopping at every step, but if he can climb 2 flights of stairs at a reasonable speed, then that meets our goal of 4 METs, which makes him okay for surgery. Or if he can walk 300 or 400 meters without stopping, that also comes to around 4 METs, which is okay for us. So we have to assess his exercise capacity. We have to see for any. So basically, broadly in the history, I think that will cover most of it. Examination, we have to see, of course, the physical findings in the chest. We have to see whether he's malnourished. We have to see how dyspneic he is. We have to see whether he's using accessory muscles. We have to see if there's any added sounds in his chest. We have to see his neck. We have to see the shape of his chest. We have to see whether he's comfortable while he's talking to us, or whether he's getting breathless while he's talking to us. And on the basis of all that, we have to decide whether we want to make this patient fit for laparoscopic cholecystectomy. I think broadly.
Just to summarize it, when we talk about the preoperative assessment in a patient respiratory part for preoperative assessment, we first do the assessment to rule out the differential diagnosis of COPD, that whether asthma is there or CHF is there or bronchiectasis. Then we categorize the patient COPD. There's a GOLD classification which came in just 2023 for the postgraduates, and the Modified Medical Research Council dyspnea scoring also came in 2023. So they just have to read it, and how much patient is optimized, and which all medications patient is taking, and how much is the compliance of a patient for that medications.
Yes, depending upon what findings we get, we will either ask him to be further optimized, or if he's in a stable phase of COPD and he cannot be improved any further, then we can proceed for the laparoscopic cholecystectomy. As far as the preoperative investigations go, there is, in my mind, there is no really role for anesthetists for preoperative PFT. PFT may be done by the respiratory medicine people to assess the patient's condition and to see how bad, or see which category. As you said, the classification is based upon the ratios and the anticipated FEV1, whether it's more than 80% or 50 to 80, 30 to 50, less than 30. If the FEV1 by FVC ratio is less than 70, That's when we classify it as obstructive lung disease. But if we've taken a detailed history and we have examined the patient thoroughly, then PFTs do not add anything, or they will not significantly change the management of this patient. So as far as anesthetists are concerned, I personally would not order a PFT for this patient. But if he's got rhonchi in his chest, if he's got an expectoration, if he's coughing, then I will send him to respiratory medicine for further optimization, and then they can work him up as to the level that they feel is the best. If that entails doing PFT, that is up to them in order to optimize the patient.
Coming on to Deep, sir, what is your take on getting the pulmonary function test? Do you get them in every smoking case going for laparoscopic surgery? Sir, you are not audible.
So like Dr. Anju said, we don't get it done for every case. Whenever we find some findings in the chest during preoperative examination of the patient, then we may ask for respiratory referral, and that is it. And obviously then we see the reversibility in the PFT and CSI. That is usually optimized more by the pulmonologist than us. So no, not as a routine for every smoker, no.
Okay. Thank you, sir. Coming on to Deep, sir, suppose there is a patient, 60-year-old patient with the previous history of MI 2 years back, and patient had PTCA at that time, and now patient is posted for a lap hernia surgery. So what all you will look into this patient?
So we look into we go into details of the CAD, the coronary artery disease. So he had an MI, what was the function of the heart at that time and what it is now? Has he been in the follow-up of any cardiologist? And what kind of stent? What you said, it is 2 years ago, so we are okay. Most of them are still somehow continuing on antiplatelets. So we usually continue with aspirin and we stop the clopidogrel if it is still there. If it is only aspirin, we just let it continue. We do not stop aspirin. And we also look at their exercise capacity at present. And most of them, many a times, Professor Sood will agree that many patients are, especially those 60 and above, they are very enthusiastic about telling us that they have been sports people and all that, but then usually the wife chimes in saying that how many years ago was that? So you have to take with a very big pinch of salt for the self-reporting of their exercise capacity. Then with looking at the minimum that they will undergo will be an echocardiography before we take them up, consider them fit for anesthesia. And if we find any low ejection fraction, any significant valvular lesions, stenotic or regurgitant, or any chambers which are dilated, then like Dr. Gulbani very rightly said, for the last few years, we have been sending cardiac biomarkers, the TROPS and the NT-proBNP. Surprisingly, at least in our center, I don't know whether it is the cardiologists are mostly driven to put in stents or whatever, but they were not doing these kind of biomarkers, and they would flatly ignore even if we confront them with a high NT-proBNP. So, but of late, yes, they have come around to the fact that this also needs to be addressed, and we know that it is significantly associated with perioperative morbidity and mortality. So cardiac biomarkers, echocardiography, and then if it is going to be a major surgery, then an stress echo will also be called for.
Two things I like to ask, sir. Do you advise echocardiography in any patient who is above 40 and is a known hypertensive?
It depends on, again, the kind of surgery that you're performing. If it's any major surgery, you see, if it is just a toe fracture or some small surgery, then obviously not. But anything intermediate or high-risk surgery, yes, we do.
Dr. Akhil, what is your take in that?
Sir, again,
echocardiography?
Echocardiography, I would not, as a routine, ask for an echocardiography. I would definitely try to, like sir said, ascertain what was the functional status at the time of the stent placement, and immediately afterwards, what was the ejection fraction, and if there has been a change in the functional status since then, reported change in the functional status, then I would definitely think about getting an echo, but not as a matter of routine.
So we can take from here that routine echocardiography primarily per se, because patient is hypertensive, is not required. But yes, if a patient is going for any major surgery or patient has poor meds, then we'll go for echocardiography. Okay. Dr. Sood, ma'am, what is your take on stopping the antihypertensives on the day of surgery, especially angiotensin receptor blockers?
Yes.
You stop them?
Yeah. The only things that we stop are those. Rest of the medications they must take in the morning. That's very, very essential. And in our PSC, we are very clear and we explain to the patients that whatever you are taking on the morning of surgery, do take it. You must take it. And if it is in the evening, then usually the patient will take it in the evening. But if it's in the any time before noon, then they definitely take it in the morning.
But you stop angiotensin receptor blockers, ma'am?
Yes, yes, yes.
Anju, ma'am, what is your experience on that? Ma'am, you are not audible, please.
According to the guidelines, the AHA says very clearly it may be stopped. So it is left to the decision of the clinician. If the patient is on multiple drugs, then I will definitely stop both ARBs or ACE inhibitors if the patient is on multiple drugs. If the patient is on a single drug of this category, then if the patient is going to undergo some surgery where hypertension is anticipated, or we're planning to do it at a regional like a THR or TKR, then I will stop it, even if it's a single drug. But if the patient is going for a lap chole, or the patient is going for a nephrectomy, or the patient is going for a FES, where I expect that there's going to be a hypertensive response to the surgical procedure, then I usually would, if it's a single drug, I would usually continue it.
And we stop it, especially in the KTPs, where we do not want any kind of a fall in BP.
Yeah, exactly.
That's where we're very careful in those.
So it's left to the discretion of a hospital that what is their policy, internal policy, whether they want to stop it or not. But besides ARBs and ACE inhibitors, we have to continue all the medications till the morning of surgery. Coming on to Dr. Akhil. Suppose there is a patient, 30-year-old patient with CKD stage 4, and the patient is posted for FES surgery. So, right. Yeah. So how will you preoperatively optimize and evaluate?
Right. So starting off the investigate, obviously after a detailed history and examination, assuming airway examination, etc., is normal. If we are talking about the investigations, I would definitely want a CBC and kidney function.
Dr. Akhil,
he's got probably some issues. So just a small question till he rejoins. So many times we find patients coming to the hospital for the first time in their life, and you end up measuring the blood pressure and it is on the higher side, much higher than what we see in the guidance. So it says 150, 100 or something like that. And you are now stuck up, we don't have a back history. And even if you take up repeat blood pressure because they have been struggling to come, waiting in a line and those kind of things, hot weather. So we are not sure whether to start him upfront on a medication, give him anxiolytic, wait for a week or so, or refer to him to a physician upfront. So what do we do? Deep sir?
Sorry?
Sir, this scenario is very common in our setup. No, patients come for the first time, no back history. First time
yes.
Ends up in a blood pressure on a much higher side than what you will accept usually.
Yes, yes. So this we see a lot of people, especially coming from rural background, those, like you said, who have enter the hospital for the first time. So the white coat hypertension is, we see it, I mean, it's not a very uncommon thing too. And then obviously we, for at least a day or so, we give them some anti-anxiety drugs and see the response. If it is still diastolic remaining very high, then we tend to refer them to cardiologist or internal medicine people.
Akhil has joined, so
yeah. Dr. Akhil, so
right, sir. Yeah,
all preoperative assessment you will plan,
right.
But all specific things you like to ask in history in a patient with CKD coming for a surgery.
Right. So I would definitely start with the history of the kidney disease as such. When did it begin? How long ago? What all medications has he taken? Has he ever been on dialysis or not? If yes, then when was the last dialysis session? How long? How many times a week, etc. Then going on to investigations, if you know the etiology of the CKD, that's great. Many times these CKD patients are diabetic as well. So a brief history of the diabetic disease history is also important, whether the patient is on insulin or not, or if the patient is on OHAs, whether the sugar is well controlled or not, any history of cardiac comorbidities, hypertension. These patients are generally hypertensive as well. So an important drug history is an important component of pre-anesthetic evaluation. Talking about investigations, obviously a CBC is the basic requirement. I would definitely want a kidney function test, blood urea, serum creatinine. Serum creatinine basically because I want to know a baseline so that we can follow the patient. If there is a acute kidney injury intraoperatively, you can follow the serum creatinine as well. And electrolytes are an important factor as well. Many hyperkalemia in CKD patients is a known complication, so definitely you want that. ECG, chest X-ray. CKD patients can have pulmonary edema, can have fluid overload, so you want to rule out fluid overload features on the chest X-ray. ECG, obviously, any cardiac issues can be revealed on the ECG. Electrolyte abnormalities can be seen on the ECG as well. And depending on his functional status, again, echo, these patients can have diastolic dysfunction as well. Left ventricular hypertrophy is a common feature in these patients. So depending on what their functional status is and what is their history of cardiac evaluation, I may or may not ask for a echo. But again, that will come later. Only if there is a suspicion that there is ongoing diastolic dysfunction, I may ask for an echo.
Yeah, just to summarize it, whenever a patient of CKD comes, there are 4 steps on which we decide and do the preoperative assessment. Like, what is the cause of CKD? Hypertension can be a sequelae of CKD, and hypertension can be a cause of CKD. And what are the end organ changes patient is having secondary to CKD? What all treatment he is taking? What is his compliance to the treatment? Dialysis, what's the duration of dialysis, how much ultrafiltrate is removed during that dialysis. Coming on to that, suppose that the patient is on dialysis twice a week, and such a patient comes to you for a FES surgery. Do you get a dialysis done one day prior?
So FES surgery, I do not expect a lot of fluid shifts during the surgery. Therefore, I will not insist on a dialysis one day prior to the surgery. If it was a major surgery where you expect a lot of blood loss or fluid infusions, I will ask for a dialysis to be done one day prior to the surgery. But short answer, no, I will not ask for a dialysis immediately before the FES surgery.
Dr. Jayashree Sood, what is your take in it?
It depends. When we usually ask the frequency of dialysis. Now, supposing he's taking thrice a week and something was due the next day, then we usually do ask. So depending upon the frequency, we do ask for a dialysis the night before, the day before, and then repeat electrolytes. So that's our usual thing.
But definitely we'll not get a dialysis done on the day of surgery because of fluid shift.
And a day before, not on the day, not on the day. A day before, and then serum electrolytes, etc. Not on the day.
Yeah. Anju ma'am, any difference in opinion, or you will go with the same thing?
I think I'll go with Dr. Jayashree. If the patient is on twice or thrice weekly dialysis, I think it's a good idea to get it done before you go in for the surgery, because he's going to be due for it then probably the next day after the FES. So it's better to, I would probably ask them to get a dialysis done the day before, like ma'am said. Because he's requiring.
Especially if there are some high potassium or something like that, that definitely would like to get it done.
Yeah.
Yes, obviously, if there is a dyselectrolytemia present, then obviously dialysis would be the way to go.
Coming on to Dr. Akhil, let's see a scenario: a patient known diabetic for the last 20 years and coming for a routine lap cholecystectomy. So what all preoperative evaluation you will do?
So a diabetic for the last 20 years, definitely a history.
And the patient is on oral hypoglycemics.
So a CBC, how old is the patient? Do we know, sir?
60-year-old patient, diabetic for the last 20 years, and patient is well controlled on OHA, and patient is posted for lap cholecystectomy. So what all preoperative assessment you will do, and what all investigations you will ask for?
Okay. Physical history, a history and a physical examination. Specifically talking about the diabetes, what medications he's been on, has ever been on insulin or not, any history of any diabetic emergencies in the past, any history of recent infections. The patient says he has good glycemic control. In the investigations, I would like to confirm that by looking at an HbA1c. I would definitely like CBC, electrolytes, and HbA1c, and ECG and chest X-ray because the patient is above 60. So these would be my requirements.
Another thing, dilemma which we usually face, should we switch over the patient from OHA to insulin prior to surgery? Let's say for a laparoscopic cholecystectomy. Major surgery, yes, we shift from oral hypoglycemics to insulin. But for intermediate surgery like laparoscopic surgery, do we shift them to insulin or do we continue with OHS?
So the answer to this question would lie in the answer to another question, is that when will the patient start eating orally again? When is the patient going to be orally allowed again? Lap cholecystectomy, usually in our setup, the patients are orally allowed by evening. If they are operating in the morning, by evening time, they'll be allowed sips of water and fluids. And then probably the same night or the next morning, they are allowed to eat. So I would not personally switch the patient to insulin. I would continue the patient on OHS.
Dr. Deep, sir, any difference in opinion with that? So you are not audible. Yes, sir.
I agree with Dr. Akhil in the sense that no need to switch him from OHA to insulin. But again, being in private sector and between private and Sarkari, there is a little difference in, the clientele's expectations. So we go maybe a bit to the overcautious side. We would also get a 60-year-old diabetic. We know the incidence of silent ischemia and things like that. So we would get an echo done.
Okay, sir. But definitely you will not shift every patient of OHA to insulin therapy.
No.
And Anju ma'am, do we stop metformin because it says that there's a risk of renal tubular acidosis? So do we stop metformin 24 to 48 hours prior to surgery? Or the patient continues just till day before surgery and skip the morning dose?
Actually, I think the guidelines have really changed. It was very old thought that you stop at 48 to 72 hours before, and then they realized that the acidosis was more a problem with the fenformin rather than with the metformin. So for many years, we have been continuing it up to the day of surgery and maybe stopping it on the morning. But now, in fact, the recent guidelines suggest that you should give metformin even on the morning of the surgery if the patient is expected to miss only one meal. So supposing the THR or TKR, where the patient will definitely eat in the evening, you could give him his morning dose of metformin. It helps to maintain a sugar control to some extent. If the patient is for a hysterectomy or where he's not going to be eating the same night, then it's a good idea to discontinue it. So in surgeries where the patient is not going to miss more than one meal, it is recommended to give metformin. We are actually following that. And acidosis is not a problem unless the patient has severe hypotension or there's some very major surgical procedure where renal blood flow is going to be compromised. In that case, also, maybe one should think of stopping metformin. Otherwise, for a lap chole or a routine surgery, there's no need to stop metformin. I think in cardiac surgery, it is still recommended that you stop it and you 48 hours before, because there is a risk of acidosis in those procedures, but not for non-cardiac surgeries. And in a 60-year-old, sorry, Akhilesh. In a 60-year-old man with 20 years of diabetes, I would be very, very scared of autonomic neuropathy. I'm very scared anesthetist. I would be taking a very detailed history of autonomic neuropathy. And I think depending upon what the history has to be very, very detailed. And depending upon that history of the microvascular and the macrovascular damage, which has probably been done by diabetes for the last 20 years, then maybe echo and whatever, maybe even more than that, depending upon what the history tells us.
Yeah.
If I can ask the house a question, like Deep sir said that echo. Sir, would you like a static echo, or would you advise a dobutamine stress echo or a treadmill test?
So if there is anything grossly abnormal in resting echo, then a stress. Otherwise, a resting echo for a lap chole is, if it was obviously a pancreatic or duodenectomy, esophageectomy, then a stress echo, yes. So it depends on the extent of the surgery. Can I also ask one question about the SGLT2 inhibitors? What about them? What is the current thought of the house? Do we stop them? Do we continue?
Sorry, Deep, could you repeat it?
The SGLT2 inhibitors, the drugs which are used in for diabetes, blood sugar control. What is the current thought? Do we stop them? Do we let them continue? Like the Flozins and all those. The guidelines say that you have to stop them 3 days before. Are we doing that, or what are we doing actually?
Yeah, they should be stopped 72 hours before, because the risk of euglycemic ketoacidosis. So we are stopping. We are not getting very many patients. Ours is a poor clientele. We are not getting very many patients on these drugs. But when we do get a patient, then we do stop them 72 hours before.
And since you're on the topic of OHAs, I think the newest trend is the GLP agonist, the glucagon-like peptide agonist. Although they are not officially available in India, but some on the people who are more affluent get injections and oral medication as well. So recent studies show that these medications increase the incidence of PONV and aspiration. They reduce gastric motility and can increase aspiration risk. So we have to be careful about that also.
Coming on to last topic, because I think we will be running short of time also. Dr. Nishkash, can we continue or we have to stop?
We can continue maybe because people are still logged in. We have about 90 odd people joined, and discussion is interesting. I'm sure it can be never ending, but we can at least complete the thing which we decided.
So we take a last scenario of a thyroid case, a patient with a huge multinodular goiter coming for total thyroidectomy. So what will be the preoperative concerns, Dr. Akhil?
So I think very interesting that you asked me this, sir, because I just came from the OT after doing such a case. This was a huge mass, 8 into 8 centimeters. 45-year-old lady who had this mass for the last 25 years. And she presented to the hospital because for the last 3 months she had stridor while lying down and then progressively while sitting also. So this was a huge mass. I would obviously a detailed history and a detailed examination, a more detailed examination of the airway would be very important here. I would like to know how the growth started. Was it soft? Was it hard? Whether she has breathing difficulty while lying down. Are there any aggravating or relieving factors? Does it help her to breathe if she goes into a particular lateral position? Does she have to wake up at night because of the stridor or apneic episodes? What relieves her symptoms? And obviously any history of hypo or hyperthyroid symptoms as well, any history of tachycardia, weight loss, or excessive weight gain or shivering, anything which might point towards any thyroid dysfunction. I would definitely in such a patient like to look at the imaging. this would be extremely important to know what kind of airway I'm dealing with. So this particular patient had a retrosternal extension as well. It was around in the neutral position. It was around 6 centimeters retrosternal, but they did a CT in the extended neck position as well, and the extension came up to about 2 centimeters retrosternal during extension, full extension. So, and obviously we also looked at, I specifically looked at the narrowest part of the tracheal lumen. And in this case, it was around 7 millimeters was the narrowest narrowing of the lumen. So yeah, and obviously the rest of the investigation like CBC, ECG, chest X-ray. Chest X-ray would obviously give me more information regarding the tracheal deviation, AP and lateral views, and the compression, AP and lateral compression of the trachea as well.
Okay. One thing, suppose there is a large multinodular goiter and Pemberton sign is negative and patient doesn't complain of any dyspnea prior to on lying supine. Do we get CT chest primarily for anesthesia workup? Surgeon doesn't want a CT chest to be done, but should we get it done? Jayashree Sood ma'am.
History plays a very important role, as Akhil was saying. So if history does not point out to anything like that, there is no need. Okay. So history, whether the patient is dyspneic while lying down or is relieved on the lying down by taking the lateral position, those history taking is very important. So CT in everything is not important. And even your retrosternal extension can be assessed clinically or by your chest X-ray. So we have to take a call on that. The only thing I wanted to say was, I don't know whether Akhil mentioned about the indirect laryngoscopy. So ENT he may have mentioned it should be documented.
Right.
Yeah.
Anju ma'am, you'll go with that or differ slightly on that?
About us ordering a CT? No, I agree. No, I think it's very rare that they should not feel the need, but we need. They will feel the need before us. So I don't think I've encountered a case where I would ask for a CT and the surgeons have not got it. But we must look at the CTs that the surgeon has got done. We must, as anesthesiologists, we must view all the imaging that the surgeons have got done.
A small comment. So important in PAC of late, I've realized that we should have a discussion with the surgeon beforehand, in addition to doing investigation, because investigation many times will not tell us, but we should know what they want to actually do, what are our concerns, and what are the challenges they are likely to face. Sometimes some patients are more tricky. So that solves most of the issues either side.
Absolutely.
So that would be done definitely for all cases.
Yeah, pre-op as well as before you start. It's very important to have a discussion, especially in these tricky cases, of course.
So I'd like to thank all the panelists, Jayashree Sood ma'am, Deep sir, Anju ma'am, and Dr. Akhil for such an enlightening discussion. Any questions?
Dr. Niskars, I'm Dr. Arvind Arya. Actually, I have to say some points regarding legal point of view, actually, because we are studying medical legal for a few years, and we have studied many cases of Delhi Medical Council. And you must be astonished to know that, are you listening? Awaz aa rahi hai? Almost 1/3 cases of medical legal pertaining to the anesthesia are related to the faulty PACs or some deficiencies in the PAC. PAC is a big legal document. Always remember it. जब भी कभी भी legal problem होगी in the anesthesia induction, the DMC and the police will have the view of it. And even all the jurisdictions, courts and consumer courts, they take very strict view of the PAC. One. Secondly, we have to also always follow, because the only one guideline, that is the ISA guideline. We must read ISA guidelines so that everybody should be aware what is there. Most of the time, we never study what actually our ISA, because this is the one thing which will be you will have to present in the court. Thirdly, is the important legal aspect is that the person who is providing the anesthesia must have to examine the patient. This is the legal requirement. Means if a team of an anesthesiologist is there, so the one person from them must do the PAC prior to the surgery. That's why there is a concept of immediate PAC. Even if somebody else has done the PAC, you must have the immediate PAC notes there available in the case sheet. Thirdly, this is very important. Never miss isolated hypertension or something. Always go for the referral, because I myself is implicated in 3 cases where there was one case where was only the hypertension during the just when I examined the patient, it was having the hypertension. Otherwise, there was no history. Repeated BP already known. But because we have not done the physician referral, then the court took the DMC took a strict view of it. That's why you have not sent the patient to the physician. Even if you are having a single case of a single reading, there is no harm of the referring the patients to the physician. One thing more, always point out and write the negative history. Negative history very important. You must document, like if allergy, previous surgeries, or something else. And also, Dr. Deep Arora sir has said significantly they are doing this chest X-ray ECGs above the age of 60. But our legal point of view, they say that above the 40, even if the patient is asymptomatic, you must get the chest X-ray and ECG to be done, and that must be placed in the file. That is my file side from the legal point of view.
Another suggestion, the DMC now recommends that there should be a separate anesthesia consent as well.
Yeah, that's true.
Most of the time, we at least in the government sector, we are not very particular for it is a general consent or a surgical consent is taken, and no anesthesia consent is taken. So one should be very particular during the pre-anesthetic checkup. Another thing I just want to know, you mentioned about hypertension. So for the benefit of residents, suppose the BP lab chole patient, 60 years old, has a BP of 160/100. Will you go ahead with anesthesia or would you not go ahead with anesthesia?
किससे पूछ रहे हो?
Anybody, 160/100. Previously the readings are okay, or maybe is a non-hypertensive on treatment, because the resident should know it. He will come to you. Sir, madam, ये करना चाहिए नहीं करना चाहिए. So would you go ahead with anesthesia or you not go ahead with anesthesia?
What we do in our hospital is, if the previous readings were fine, okay, recorded, but definitely acceptable by a doctor, not a farji one. If the ECG, X-ray were also normal, no hypertrophy, then we would definitely accept it, give a little pre-med in the pre-operative room, a little bit of full SED and counseling, and usually it comes down. So this is our protocol.
So what is the higher limit of systolic and diastolic blood pressure you will accept on the day of surgery?
On the day to वो पहले देखेंगे ना, but naturally if it is going above 180,
पहले के readings शायद normally थे, morning में BP बढ़ा, resident पूछ रहा है मैडम cancel करें या करना है?
No, again I'm saying there's no upper limit, but usually if with sedation, with a little bit of this thing, full SED, 0.5 again, it comes down to about, say, if it was, say, even 190 systolic, and then it comes down to 150, we do accept it. But if it keeps sustained, then maybe. Because we've seen that in X-ray and ECG, there is no cardiomegaly, there is no hypertrophy. So we know that there are no chronic changes. So this is our protocol usually.
We can say that if the patient is well controlled on antihypertensives and on the last PAC, because there should be a PAC done, immediate PAC. So in that, the blood pressure is normal. So we'll not take too much into consideration the BP on the OT table.
Absolutely.
Yeah, actually, Barash mentions that maybe a higher limit of 160 and even 110. They quoted a few studies that the incidence of cardiac events is not much different in a normotensive patient or a patient with high BP. I ask this question because most of the time such patients are cancelled and never taken up for surgery. So
I want to make a comment on this.
They should not be cancelled so easily.
Actually, मैं बेहोशी वालों के साथ ना cancellation केस का ना पता नहीं वो एक so called ना जुड़ गया है, वो उसमें lot of credit goes to us. So only thing is that whatever we do, there is no case which we cannot do. The only thing is that surgeon should know that, and patient should know whether risk is worth taking. That has to be clearly explained.
No, Dr. Nishkarsh, I am not saying a resident will ask whether it can be done.
Yeah, I agree, sir.
I am not saying we should cancel a case.
No, it was not on that. It was general this thing that at anesthesiologist, we must ensure that surgeon will understand the complexity of risk you are taking. That has to be ensured, irrespective of whether it is hypertension, diabetes, obstructive sleep apnea, anything. But if they know about it, then things become much better, because they also know there is a complex case. They will do it faster. They will not do it.
Hey, that's true. But as we were telling Lokesh, I'm sure Dr. Deep will also agree with me that we do not cancel.
लोकेश सर के तो मैम सबसे बढ़िया केस होते हैं. अब you don't know, but
Of
all
course.
cases nobody does. लोकेश सर के ओटी में सारे केस होते हैं.
I know that, of course. और कहाँ नहीं होते वो भी पता है.
Ma'am, another suggestion nowadays in the ward we have saturation monitor available. So during our PAC, in a patient who is giving a doubtful history of some problems, a baseline saturation, and also a fall in saturation following activity, what you call pulse oximetry, is a very simple test which may help in identifying patients at risk, so that whether they need further evaluation or not, that can be seen. So it can be tried. It is in the thoracic anesthesia, usually that pulse oximetry test and fall in saturation by about 4 or 5 following some shuttle walk may help in identifying patients at risk and further assessment.
Yes.
Sir, similar to this, suppose a patient...
Deep, you are on mute, I think. You want to say something, Deep?
Yeah. Yes. From what you're saying, you brought a very important point, especially after COVID. We have come across many patients who had bad COVID, and they come for totally unrelated surgeries, like joint replacement after 2 years of that. And we have come across such patients having a very stormy post-op period with a lot of desaturations. And then we started investigating them more thoroughly, sending them for pulmo. And then a lot of them had a CT done, which showed a lot of fibrotic changes, which was not evident on a normal chest X-ray. So history of COVID, we should, keep that in mind, that a lot of chest, lungs, tissue may be destroyed because of previous infection.
Yeah. Similar to Lokesh sir question, suppose there's a patient who is a known diabetic and preoperative blood sugar, serum fasting and PP are normal. And patient HbA1c is around 7.8 to 8. But on the day of surgery, the sugar comes around 200 milligram per cent.
I was about to ask that question. I thought, yeah. So experts may please guide us on that.
Akhilesh, फिर से बताना, please. Sorry.
Ma'am, a diabetic patient on OHA, blood sugar fasting PP was normal, and HbA1c is around 7.5. And on the morning of surgery, the blood sugar comes out to be 200 milligram per cent. So what should be our take in that?
Has he been... Anju, would you like to answer? Then I'll give my comments. Is he already on insulin?
If he's well controlled earlier and he's been okay until the morning of surgery, then I would start glucose insulin in the pre-op and maybe tell the surgeons to take it up in the next as a next case, so that we can get the sugar down to below 180, so that we don't have problems with wound healing and infections.
Ma'am, secondary to that, suppose HbA1c around, we get HbA1c around 8.5 or 9, because HbA1c tells about the control over the last 3 months. And the patient's blood sugar were okay. For the last 1 week, they are okay. So should we give too much stress on HbA1c, or we'll go with the blood sugar levels?
No, I think, Dr. Akhilesh, when you have this HbA1c, then you should again take a very delve into the history for microvascular, macrovascular, autonomic, see the damage done by that sustained blood sugar. But at this point in time, if the blood sugar is controlled, I would take up the patient after doing again a proper detailed probing evaluation into gastropathy, autonomic neuropathy, and all these damages due to the diabetes. But I would not cancel the case because there's HbA1c, but we know that he might be damaged by the diabetes, and take due precautions, or take a very, I tell my residents, a very detailed, when you see this sort of a situation, you become an investigator and you investigate, probe for these problems, and then carry on.
A slightly different take on this, because we do a lot of joint replacement, we put implants. So our cutoff of HbA1c is 8. Anything beyond 8, we send the patient back for further optimization, better control. They can come back to us when the HbA1c is less than 8. On the day of surgery, if it is 201 off reading, then like Dr. Anju said, we start the infusion and we bring it down to less than 180. A lot of surgeons now believe that it is not only HbA1c, but it is also the perioperative blood sugar levels. If they are sustained over 200, 250, then the chances of infection get high in the perioperative period, because many of them have been on steroids or they get steroid supplementation. So we have to be very careful, because some anesthetists, especially in our setup, like dexamethasone is part of the multimodal regime. So you have to follow up whether it is causing a spike in blood sugar. So you have to be very watchful of all these facts.
Anything anyone wants to add on
Dr.
something?
Akhilesh, here actually I have seen the role of Dunn phenomena Sogome effect is quite high in many patients actually. So if you so they are having well controlled diabetes, but many times in the morning levels are too high. If we have the first case, we usually see the blood sugars maybe in around 160 to 100. But I think if it is well controlled within 200, then we should not cancel the case.
Yeah, thank you. Dr. Akhilesh.
Yeah.
Dr. Yeah. Actually, a lot of our audiences are postgraduates who are among us. I can see that. So I have two things, if my esteemed panelist can put a light on it for them. Number one, we are getting a lot of kiddos in most of our setups these days. So, and because of the seasonal variations, these kiddos may have upper respiratory infections, say cough or something like that, but the chest is absolutely clear. So in a light of prey, right, that is there, what is the take to be given to residents from my esteemed panelists that to go ahead with the surgery, or what are the guidelines? And second question, and the second thing which I want my panelists to highlight is, how about the routine pre-anesthetic advice being written by the residents doing PAC? At some centers where we all agree that we go for taking exams and all, we find that people are still routinely giving acid prophylaxis, antiemetics, and all those stuffs. So if my panelists can tell these people that what should be the routine advice, what not to be given.
For the children, history is very important, and history by the parents. So yes, like if you have this rainy season or the winter season, very often the children have a cough. So fever is a very important symptom which is given by the mother. So if the patient has fever, then it indicates a lower respiratory tract infection. And there you can advise a little postponement, definitely. But otherwise, just a cough and a little bit of coryza, you will not postpone. So that's very important. And wherever you can use and you are comfortable with a supralaryngeal, that's the time you should use a supralaryngeal. And while the others will also give their remarks, second question that you had about the preoperative advice, was it regarding the fasting or anything? Sorry?
So Dr. Amit, you are not audible.
What was the second thing about preoperative
Dr.
advice?
Amit,
yeah, second thing which I wanted that, ma'am, the panelists should tell for the sake of the residents out there, that what are the pre-anesthetic medications routinely not to be given.
Before medications, even the fasting guidelines now, Amit, are very important. Even in our place where we have set all the guidelines, but still sometimes the patients say, "Humne raat se kuch nahi khaya." So education of all the surgeons as well, to allow them that you, of course, you need not say just 2 hours before surgery, that may be difficult, but at least 4 hours, till 4 hours before surgery, you can advise your patients to have water, clear water. That's very, very important. And as far as these other things, usually they are not given now because the drugs are so good, are anesthetic agents, that you really don't have these things. And of course, if you want to give naturally, PONV prophylaxis, we give in joint. So that's the routine we follow in our hospital.
Anju ma'am, your take.
Can I? Hello. Can I speak something? I'm
Sanjeev.
I'm Dr. Sanjeev Popli. Madam knows me. Dr. Jayashree Sood, madam knows me well. I was just inquiring, what is the role of CT coronary angiogram? Does anybody do that before this TKR and all this? Because Deep also is into private sector, and he could also know their importance, because a lot of times when the surgery is extended, the stress, it can be post-operative that the patient infarcts. There's a cardiac insult. And that happens mostly post-operative because of the prolonged procedure. So, and also a echo as a tool in a PSC room, just for the evaluation of residents and consultants even, can provide light to the degree of hydration to be maintained in the theater in view of, high creatinine and all, whatever issue, the IVC and all these issues are addressed by a simple echocardiography. And if a CT coronary is not done, then at least a stress echo can be done. In a case which is, as you described, 60-year-old with 20 years history of diabetes, these things can spill over into post-operative problems. While a cholecystectomy takes hardly 20-25 minutes these days, because everybody is doing it so well. I was just keen to know, MAMC has that facility, our thought in mind, because I have been there. And so Anju can also let us know.
So you are asking whether we'll order a CT angiography for a patient undergoing TKR, basically.
Yeah.
When we talk about evaluation of a patient with suspected or known CAD undergoing a major surgical procedure, then I think an orthopedic surgery is today counted. Now they've taken away that intermediate surgery. Now surgeries are either minor or they're major. So orthopedic surgery is major. So we have to first see what is the patient's combined surgical and risk based upon certain risk factors that Michelle had told us about. So one can do this grading based upon, we can see the RCI score, RCRA, revised cardiac risk index, and see whether the patient has got a high score. And according to that, and then we can assess his functional capacity. And depending upon these two factors, if the patient's functional capacity is more than 4 METs, in a TKR, sir, our anesthesia technique will not really change unless patient has got a very critical CAD. So then I would send the patient to GB Pant and ask for a cardiology evaluation if I feel that the patient has got a significant CAD, and let them decide whether the patient needs a CT angiography or the patient needs a stress echo. Surprisingly, in GB Pant Hospital, which is attached to MAMC, they do not do stress echo. So if they suspect that the patient is got a significant coronary artery disease, they straight away go for CT angiography. So we have
they go for a conventional angiography.
So they go for conventional ecography, but if they feel that will not serve the purpose, then they go directly for CT angiography. So in many of our bariatric patients also, if the patient has got multiple comorbidities, diabetes, long-standing hypertension, CAD, then they do CT angiography for the bariatric cases. Not for TKRs, never, because it doesn't really change your anesthetic technique. I agree, sir, post-operative stresses will be there, but our technique will not be changed by getting a CT angiography if you've taken a good detailed history. Our management of anesthesia remains much the same.
See, what happens is most of the times when the surgeons looks at the ejection fraction being around 20-25%, he's scared of going ahead with the surgery. So yes, he is always advising go for the cardiac evaluation in the progression.
Yes, so definitely 20% ejection fraction, anything below 40%, definitely a cardiology evaluation. And their advice as to whether the therapy needs to be modified or the patient needs any other intervention, because TKR is not an emergency. So, I mean, we would leave it on the cardiologist, sir.
So that's why particularly I mentioned about it, not cholecystectomy, because cholecystectomy patient might be in severe pain and the urgency for the family to get rid of the pain factor.
Yes, sir.
So So
Yeah.
I would leave it to the cardiologist, sir, to decide what they want to do. But definitely for medical, legal, and for our safety, we would definitely get the cardiologist in the picture. Definitely.
We never order the CT angio ourselves.
Yeah. Thank you, ma'am. Thank you, ma'am. Thank you.
Thank you, sir.
Thank you. Thank you, Anju.
Thank you, sir.
So, these final comments? Mute or mute?
Yeah. I'd like to thank all the panelists for a wonderful discussion. And as we have seen that taking a good history is of utmost importance, and we can diagnose lot many things, we can assess lot many things prior to giving anesthesia. And yes, referrals are important as and when required. Jayashree Sood ma'am, your final comments, please.
Yeah. Yes, Akhilesh, pre-anesthetic assessment, very, very important. It must be done. There is no question of omitting it. A good history gives you a lot. So you don't have to, as of course, Dr. Arvind was telling us a lot, if you get stuck in a DMC case, in a medical legal, but if you have a good history, a good examination, and if you document everything, which is very important, things will be fine. So those things you must remember is the documentation. Don't miss all these parameters. Simple things like allergy, past history, and in the examination, BMI and basal saturation. If you do all those things, and even in the advice to the patient, if you tell them properly everything, counseling, it plays a lot of importance, and this will help you a long way. Not only in conducting the anesthesia, but ensuring you'll be making sure you don't get into any trouble with medical legal hassles.
Anju ma'am, your final comments, ma'am.
I think it was a very good session, but I would also like to emphasize, I'm a great believer in history. 90% is history. I mean, Dr. Michelle told us so many risk indices for so many conditions, and none of us can remember them. We can learn them and then we will forget them. So if you take a very detailed history, for that you have to know what to expect depending upon the surgical cause for which the patient is coming, the history related to that surgical problem, and the history related to the patient's medical problems. You actually have to probe whether it is a private setup or a government setup. In the private setup, as Dr. Deep said, the patients are so cool. They tend to be, ride over everything, and they will deny everything because they think they're so cool. And in the government setup, patients are, of course, relatively uneducated. So you have to probe. As anesthetists at that time, we have to probe, and that our detailed examination history will tell us much more than any of these, formal indices. If you can't remember them, it's quite all right. So look at the patient, diabetic hair, you look at everything, microvascular, then you have to learn. As students, the PGs have to study, you have to know your subject. In a diabetic patient, ye sab hoga. In a cirrhotic patient, ye sab hoga. In a CRF patient, ye sab hoga. And then you have to probe and actively extract history. And if you do that, you'll be very safe anesthetist. So if any event happens, you know what is happening and you can manage it. That is the take-home message. I think that preoperative evaluation is basically for this, apart from a whole lot of other things. Thank you very much to the whole team.
Sir,
thank you.
Your final take-home message. Sir, you are muted.
Thank you. A great initiative in starting this kind of interactive session. I would just reiterate what Professor Sood, Dr. Anju have said, that history taking is very important. Documentation is even more important. And going forward, we cannot escape from the role of AI, which is coming in. And Dr. Michelle, she enumerated so many scores. Once you have everything on your iPad or your smartphones and all these scores can be, then it will give you a more objective kind of, stratification and risk stratification. So I think going forward, that will be the way. But till then, even then, there'll be no taking away the importance of history taking and examination and documentation.
Dr. Akhil, your final comments, please.
Sir, everything has already been covered by everyone else. The only thing I would like to add is that PAC or the pre-anesthetic interview with the patient gives us, the anesthesiologist, one opportunity to actually build a rapport with the patient. Why should only the surgeon be the one who is asked for by the patient before induction, right? If you have a good interaction with the patient, it gives us an opportunity to build a relationship with the patient as well. And obviously, history taking is an extremely important aspect, which will obviously help you do that. So that's it from me. Thank you,
Akhil, very important point. And you must teach the students that they must introduce themselves. That's very important.
Yes.
Over to Dr. Nishkarsh for closing it.
Lokesh sir, final words of
wisdom. Just the suggestion, maybe with the workload, it may be really difficult for the anesthesiologist and for the patient to come to the PAC clinic. In some of the Western countries, they have a nurse-led PAC clinic, or maybe a performer or an app can be made in which major cardiac or any diseases can be ruled out or can be informed by the patient, so that any patient who cross a limit may be referred to a anesthesiologist and relevant physician, so that it gets more streamlined, because that way the patient will himself say that maybe he has a cardiac disease or he doesn't have a cardiac disease. It might decrease the workload and may rationalize the thing. The session was really good. Thanks very much for such an informative session. Dr. Akhilesh, please.
Yeah, thank you, sir. Can we just conclude, Dr. Nishkarsh?
Thank you, sir.
Thank you, Lokesh sir, President ICA Delhi and HOD Anesthesia Department, Main Hospital, AIIMS Delhi. I thank Amit Kohli and the whole ICA Delhi team for this wonderful initiative. Initially, we thought we'll have some lectures, but then we decided to have panel discussion. We were a little jittery whether panel will work on Zoom, but I find it is really effective and we could keep people engaged. We touched about 100, which is a good number to begin with for a webinar. I thank all the panelists and the speakers for sparing time on a short notice. And we will continue this, as Amit said, on specific dates and not the days, so that there is not much conflict with the other webinars which are going on. And we hope to see you again in another 15 days from now. Thank you very much. Amit, you want to say anything before we end?
Yeah, I really, initially, Dr. Nishkarsh, have thanked everybody. I'd like to thank Dr. Nishkarsh, right, who's our academic coordinator for ISA Delhi Academic Series. Right, it's his efforts in selecting the topics, in selecting the panelists and the speakers. So I congratulate you, Dr. Nishkarsh. And I really want to thank all my governing council members, our president, vice president, treasurer, editor, and all governing council members who are studying along with us, right, in all our ventures from ISA Delhi. And this is there. And Sood madam, we knew that you have another webinar of ICA started at 7 o'clock, but still you are with us throughout our webinar. It's commendable.
I told them.
That is there. Really want to thank you. Thank you all the panelists, Dr. Deep, Dr. Anju, and Dr. Akhil, along with Dr. Michelle, right? And hope to see all our residents in the same numbers the coming session. Thank you very much.
Thank you very much.
Thank you.
Thanks a lot.
Thank you.
Thank you, Akhilesh. Thank you.
Thank you, ma'am. Thank you.
Thank you.